In this lecture, we're going to be talking about abnormal psychology, what was traditionally known as abnormal psychology, but now it's got a new name. It's psychopathology. In this lecture, we'll talk a little bit about kind of how historically mental disorders were viewed, and then what goes into the diagnosis of a mental disorder, because typically people go to their doctors to be treated or diagnosed, and that is not how it's supposed to be. But before we begin, here is your dad joke of the day. Why don't eggs tell each other jokes? Because they crack each other up. Ba-dum-tsh. Let me get my handy-dandy pen, and let's get started. If you ever consider going to medical school, which you may or may not, you may experience something similar to this with either clinical psychology or medical school. When students are learning about diseases, they often misunderstand a description of a disease and confuse it with a normal condition. So, for example, if they're learning about a disorder where they have itchy ears and they, one day end up having itchy ears, they might think that they have the disease that they're learning about. It can also occur with psychological disorders, so for those of you who may end up going to school to be therapists or clinical psychologists, you might encounter this yourselves as you learn about the different disorders and their symptoms. But the key with all psychological disorders is not whether you have symptoms or not, but rather whether the symptoms you have are interfering with your life in some way, making you unable to meet your responsibilities and obligations, or they're deterring your quality of life. You're not enjoying life, and life is really, really difficult as a result of the symptoms. So the American Psychological Association, which is kind of the umbrella organization for all things psychological, defines abnormal behavior or psychopathology as a clinically significant disturbance in an individual's cognition, which is thinking, emotional regulation, or behavior that reflects a dysfunction in their psychological, biological, or developmental processes that are controlling some sort of mental functioning. So I abbreviated that last bit. But a diagnosis, despite this definition, unfortunately, is not that easy. So when we talk about psychological disorders, we're speaking about essentially a mental disorder, something that happens in your brain. And it's a condition that is characterized by thoughts, feelings, and behaviors that are making things difficult or creating dysfunction. Because of the symptoms of a mental disorder, a person's relationship can be impaired in some way. It can disrupt their ability to live with their life productively. They might not be able to think clearly or therefore communicate with others clearly. And as a result of these dysfunctions, they might not be able to hold a job or deal with stressful events. Again, making life essentially all around difficult and decreasing the quality of life. Psychopathology, which is the title of this particular lecture, is the study of psychological disorders and their symptoms. So typically with psychopathology, they're trying to study how symptoms may change or what combinations of symptoms may be found in certain psychological disorders. And then sometimes in psychopathology, they study something called etiology, which is a fancy word for trying to identify the causes of the disorders. And so when it comes to diagnosing any psychological disorder, therapists typically consider the 4 Ds: deviance, dysfunction, distress, and danger. So when we're defining a psychological disorder, we're looking for whether the behavior or a person's symptoms deviate from what is typically normal or considered normal in society. We're also looking for dysfunction, whether the symptoms are interfering with a person's ability to function in daily activities. We're also looking for distress, which is, are they experiencing emotional suffering as a result of their symptoms or their disorder? And then lastly, we're looking for danger. Does the behavior that the person exhibit pose a risk to either themselves or others? And so typically when we're looking at symptoms, we're considering these 4Ds to determine whether the disorder is in fact a disorder or just a collection of symptoms that are, not making the person that unable to fulfill their obligations. But before we go into kind of the current views of diagnosis or of diagnosing mental disorders, we're going to talk about some ancient views of mental illnesses. So remember what I mentioned to you earlier, etiological theories, or etiology represents causes of disorder. So these are causes or theories of causes underlying the disorders. Way back when, hundreds of years ago, thousands of years ago, people didn't fully understand why somebody who seemed completely functional and normal at one point, all of a sudden, it may seem to them, changed in their behavior. So they came up with these supernatural theories for the causes of the disorder. Perhaps the person is possessed by evil or demonic spirits, and they upset gods, or there were eclipses, or planetary changes, or curses, or sin. Any of these, again, were attempting to explain people's behavior when they changed as a result of mental illness, because at that point, they didn't fully understand how the body worked, period, let alone this idea that something may have changed in the brain to contribute to the mental illness. Somatogenic theories represent kind of changes occurring in your physical body's functioning that may have been caused by some sort of illness, may have been inherited from your family, brain damage, or imbalance of fluids. So the Greeks used to think that our ability to function or our personality arose from a balance of 4 fluids: blood, phlegm, yellow bile, and black bile. I'll mention that there's absolutely no support for this thinking, but this is kind of what they viewed contributed to personality, and any time any of these fluids were in excess of the others, it resulted in changes in their personality, or what they viewed as personality, but were likely mental disorders or mental disturbances. So what happens if you had too much blood or excess blood? It contributed to what was called a sanguine personality, somebody who was incredibly positive even in situations that were not very pleasant. Too much phlegm made a person what's called phlegmatic. They were very unemotional or calm. Too much yellow bile likely contributed to what they called choleric, or too much anger, and then too much black bile contributed to a melancholic personality, which we still use today, which is a really sad or depressed personality. And again, because they didn't fully understand what may have been causing disorders, one of the treatments for disorders, especially if they thought the person was possessed by some sort of demonic spirit, they attempted to release that demonic spirit through trephination. Trephination is when they surgically drill holes in the skulls as a way to kind of treat illnesses or release evil spirits that may have been trapped in the skull. And this idea was that something was happening in their brains. They didn't fully understand what. And because they thought that people were being possessed, oftentimes they drilled holes to release whatever may have been possessing the person. This, obviously, not surprisingly, didn't help at all, but it continued well into the 16 and 1700s because, again, people didn't fully understand what was happening with regard to mental illness. Another kind of view of personality is kind of this traditional Chinese philosophy that personality changed over the course of the year, just like there were seasons of seasonal changes. And so they argued that as people go through seasons, so do their personality. And so in the spring, a person may experience greater anger because of wood. Again, it's unclear why wood in particular was the focal point of spring, maybe representing growth. Summer, things get hot and dry, represented by more joyous personality. Late summer, as things get really dry and there's more dirt, represents a more meditative personality. Metal in autumn is represented as a more worry-focused personality. And then finally, in winter, as things ice over or there's snow, the personality is represented with more fear. Again, there's no real support for any of these, but they represent ways in which people were attempting to understand changes in people and what they thought were changes in personality, but really were representative of mental illnesses. When people got to be too difficult in society, they created what were known as asylums. Its purpose, they were designed to house people with psychological disorders. And because these individuals with mental illnesses were troublesome in society, they tried to kind of take them away from society instead of treating them. So they kind of box them up, compartmentalize them, and it's kind of like out of sight, out of mind, so to speak. But in the late 1700s, an individual named Philippe Pinel argued for more humane treatment of the mentally ill. They were people, for God's sakes. They weren't, horrible animals. And then in the 1800s, Dorothea Dix kind of led a charge to reform mental health care, specifically in the United States, arguing for the fact that these individuals should be treated rather than kind of housed and drugged and sedated. But it wasn't until Emil Kraepelin, in the late 1800s and early 1900s, who actually discovered schizophrenia and version of Alzheimer's disease. He is considered the founder of modern scientific psychiatry and using medication to treat mental illnesses, so psychopharmacology. He believed that the chief cause of psychiatric diseases were biological, that they arose from the brain, or they were the result of some sort of genetic mutation or malfunction. Again, when we view diseases as having biological or physiological origination, it makes treatment different versus if you're seeing them as, possessions by evil spirits, you're going to treat those individuals differently. So views of psychiatric illnesses really impact how they are treated, at least how they were treated over the course of history. Now, we view mental illnesses through a biopsychosocial model. It's this view that what's contributing to mental disorders is not just one factor, but may be a combination of biology, psychology, as well as social or environmental factors that interact to contribute to the onset of mental disorders. So the biological roots view is that abnormal behaviors likely is contributed by genetic factors, things you inherit from your family, diseases, bad nutrition, so anything that's going to affect brain function may end up being a cause for mental illness. Psychological components include how people deal with stressful experiences. Oftentimes, stress is a precipitating factor for many psychological disorders. And then finally, social and cultural context is important to dictate what is normal versus abnormal. But I also want to highlight the fact that social factors such as environmental conditions, in which you were raised, may also contribute to mental illnesses. But we do want to focus on the fact that what we consider abnormal may be culturally dependent. So, for example, if you saw a bunch of people on the slopes skiing in witches costume, you might think like, oh, these guys are really weird and bizarre. Maybe they have a mental illness if you're not expecting them to behave in this way. But this is a festival. It's a race where people get dressed up in these costumes and race down mountains. In Norway, they have a zombie day where people are dressed up as zombies and kind of parade through the streets. Again, if you were not expecting it or this is not part of your culture, you would view these behaviors as completely abnormal. So it's really important to take into account what is culturally acceptable and not before we put the label of abnormal versus normal behavior. When you go to the doctor, it's likely that you are expecting things to go a certain way, right? You're expecting to tell the doctor your symptoms. Using those symptoms, the doctor is going to diagnose you and then prescribe some sort of medication that's going to alleviate your symptoms and you're going to get better. Well, clinical psychologists have been attempting to do this for decades, right? They were hoping to reach this level of accuracy that the medical profession appears to have, but we haven't quite gotten there. What they've done to help with diagnosis is they've tried to standardize definition and criteria for diagnosing specific disorders. So they use a book that gets updated every so often. We're now in our 5th version of this book called the Diagnostic and Statistics Manual. People typically refer to it as the DSM because it's just easier than saying Diagnostic and Statistics Manual. But the manual, again, which I've mentioned, gets updated every 10 or 15 years, because we learn more about disorders, and so the criteria for those disorders and their diagnoses have to change. In the DSM, you will see descriptions or criteria or symptoms for each psychological disorder. And as I mentioned, as we learn more about these disorders, we have to change the criteria and kind of reorganize the disorders because we should be driven by the knowledge about these disorders rather than what society views as okay or not. I'll give you an example. In the 3rd edition of the DSM, homosexuality was listed as a disorder. In the 4th edition, it wasn't. And so it's really important to utilize current understanding of these disorders to update them and therefore publish new versions of the disorder. But the DSM is used by psychiatrists and psychologists as a way to better understand diagnosis and therefore treatment of different disorder. So for each disorder, the DSM has criteria for being diagnosed with a particular disorder, right? So for example, for ADHD, which is attention deficit hyperactivity disorder, the individual has to meet at least 6 symptoms of inattention and hyperactivity and impulsivity to get labeled or to get the diagnosis of ADHD. The DSM follows what's called an either-or style. So you're given a list of criteria that could be characterizing the disorder, but the person does not need to meet all of them. It sets kind of a limit or a minimum number that they need to meet in order to be diagnosed with a particular diagnosis. But because you have this either or style, right, it doesn't matter which symptoms, but they could have different combinations of symptoms. That means that some people may have the same exact diagnosis of a particular disorder, but they vary in their symptomology because they only have to meet a certain number of a longer list of symptoms. But it's been really helpful in terms of diagnosis because the DSM has established some level of consistency and standard in diagnosis. So just to give you an idea of what you might find in the DSM, I've kind of shown you criteria for major depressive disorder and persistent depressive disorder. They fall into mood disorders, but there are different types of mood disorders, and here are two: major depressive disorder and persistent mood disorder. You'll notice I've put a kind of an arrow to illustrate. They have to have 5 or more of the 9 symptoms listed below here. For persistent depressive disorder, they have to have presence of 2 or more of the same of these symptoms listed below. So you could have individuals with combinations of these symptoms that are very different, but they're both going to be diagnosed with persistent depressive disorder. To give you an idea of the categories of psychological disorders, here they are. These are all the different disorders that exist in the DSM that there are diagnostic criteria for. Different disorders are listed under different kind of umbrella terms. So bipolar used to be listed along with depression as mood disorders, but they are 2 separate disorders. But you'll learn when we talk about mood disorders that bipolar disorder shares symptoms with depressive disorder. Obsessive compulsive disorders used to be listed under anxiety disorders, but now it gets its own separate category and criteria. So again, as we learn more about the etiology or causes of disorders, the DSM updates not only the criteria, but the reorganization of some of these disorders depending on what we learn about them. While the DSM has been great in kind of helping standardize diagnosis so that when people use terms like depression or schizophrenia, everybody is using it in the same way. But the problem with this kind of diagnosis is you're going to make the assumption that any disorder is going to fit into a category and that each person is going to get a single clear diagnosis. That unfortunately is not the case because symptoms of one disorder can overlap with other disorders. And so there are people who criticize the DSM. So here are kind of the criticisms of DSM's categorical approach, the idea that we're putting people into categories based on the symptoms they demonstrate. One of the problems is that most troubled people partly fit into not just one, but multiple disorders or diagnoses. You can have genetic and environmental causes of one disorder overlapping with another. An example is the genes that contribute to schizophrenia also increase risk for bipolar disorder. Similarly, the treatment designed for one disorder is going to help with another. Currently, the treatment for antidepressants, which were designed to treat depression, can also be used to treat anxiety symptoms. And finally, they criticize it by saying that too many conditions are labeled as mental illnesses. So a person may come in and experiencing symptoms of, for example, menstrual distress, right? They might just have a really bad period cramps or experience real sadness and mood changes with their period. And then rather than trying to treat them and the symptoms, they might be labeled with a disorder such as premenstrual dysphoric disorder. So we're labeling conditions, the collections of symptoms that people have, as mental illnesses rather than just trying to treat the person and the symptoms that they're experiencing. An alternative, so those people who are kind of criticizing the DSM have an alternate approach to rating people instead of kind of categorizing them into a bucket. The alternative they propose is rate each person on dimensions of distress, understanding that you might have people demonstrating all of these symptoms, but to varying degrees. So rather than kind of putting them into buckets, rate them on these different dimensions of distress so that they might be more accurately treated for their symptoms rather than for the label that they're assigned based on the diagnostic criteria. All right, so most people, when they experience mental illness, especially at young ages, end up going to their pediatrician or their doctor, and the doctor then likely prescribes them some sort of medication as a way to alleviate some of the symptoms or whatever those patient's complaints are. Unfortunately, a medical provider such as a physician or a pediatrician is really not trained in the diagnostic process of mental disorders. A psychiatrist and a clinical psychologist is, and it's very different than a 15-minute consult that people often get with their pediatricians or doctors before they are prescribed medication. So diagnosis is referring to the hopefully accurate identification of the nature and cause of symptoms of an illness that a person is going to the doctor for. A clinician, these are individuals who are trained in the diagnostic process, is going to work with patients or clients, and they might be the ones who are diagnosing the patients, and if the treatment does not involve medication, they might work with them to provide them with therapeutic treatments to relieve their symptoms. All clinicians will conduct what's called a clinical interview and mental status examination, where they are kind of made aware of people's appearance, their behavior, what the person's reporting about their symptoms, their mental health history, as well as current life circumstances. And then they might be diagnosed with what's called a principal diagnosis, a diagnosis that is the most relevant to a person's chief complaints and the one that they are seeking help for treatment. So what that means is that this person may have other symptoms that are related to other diagnostic conditions or other conditions, but they are being treated for this principal diagnosis, the one that they came to the clinician for help, and that will be the focus of clinical attention. So for example, somebody who comes to a clinician for help with depression, but also has anxiety, but their primary concern is depression, is going to be treated for depression initially until the symptoms of anxiety become problematic, at which point the clinician may treat both depression and anxiety. Comorbidity speaks to the fact that oftentimes with disorders, they co-occur. People typically don't have just one disorder and that's it. Most people have at least two, if not more, disorders. And so comorbidity, by definition, refers to the presence of more than one diagnosis or one disorder occurring in an individual at the same time. The treatment plan, again, this is something that is discussed with the patient and developed by the clinician, is a course of action to treat the disorder that the person is coming for help with, and it is a kind of type of contract that describes the goals of treatment, the kind of treatment that they would be receiving, as well as how often they would be obtaining or receiving those treatment sessions, which is often in therapy. And so you might notice that if you have a disorder that you're currently taking medication for, you may not have undergone this type of diagnosis for your disorder. It's highly advised if you want a more accurate diagnosis, but this is one way that people end up being medicated, or it seems like so many people might be treated for disorders because they're not getting necessarily the correct type of diagnosis for, or being evaluated correctly, I should say, for their diagnosis. All right, so this is the summary for today's lecture. We need to consider what abnormal behavior is based on the cultural context. We discussed kind of historic views of abnormal behavior, Greek, Chinese, as well as medieval. We discussed the current model of mental disorders, which takes a biopsychosocial view. And then finally, we discussed at length what the DSM is and how the DSM has kind of evolved over time and how people fit into kind of more than one disorder, as well as the criticisms for the DSM. And then finally, we talked about what actually is supposed to happen when it comes to diagnosis and treatment of a mental illness. Here are your exit tickets for this particular lecture. And that's all I got for you.